flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the December 11th, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. The meeting has been posted appropriately in our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future use. Cheryl,
Okay. Director Epen?
present?
Director Wallace?
Present.
Director Nicholson?
Present.
Director Yee? Present. Director Stewart?
Present.
Next, we have the consideration of resolution number 1269, acknowledging the appointment of William Nicholson, MD, and Janie E. as Director of Washington Township Healthcare District. Resolution.
Mr. President, I move that the Board of Directors approve the resolution number 1269, acknowledging the appointment of William Nicholson, MD, and Jeannie Yee as Directors of Washington Township Healthcare District.
Second. And a roll? Roll show.
Director Epen?
Aye?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? Aye. Director Stewart?
Aye.
All right, it's our pleasure this evening to have the Honorable Thomas Nixon here to do the oath of office.
And who shall be sworn in first?
I'm the first victim.
We have the podium up here if you want to.
Absolutely.
Nicholson. I am Judge Thomas Nixon. I'm the presiding judge of the Alameda County Superior Court, and I will be swearing you in today. If you will do me a favor and raise your right hand to be sworn. Repeat after me, sir. I, William F. Nicholson,
I, William F. Nicholson,
solemnly swear or affirm
solemnly swear or affirm
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States,
to the Constitution of the United
and
States
the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely,
that I take this obligation freely
without any mental reservation
without any mental
or
reservation
purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
upon which I am about to enter.
about which I am about to enter. Thank you. Thank you.
And Ms. Yee? Good evening, how are you?
Nice to meet you again.
Could you do me a favor, raise your right hand, please, and repeat after me. I, Jeannie Lee,
I, Jeannie Yee,
solemnly swear or affirm
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith
that I will bear true faith
and allegiance
and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental
or
reservation
purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties
discharge the duties
upon which I am about to enter.
upon which I'm about to enter. So help me God.
You may not believe this, but I think you're probably the 20th person I've sworn in this year. We have had quite a spate of judges come, so I'm pleased and delighted to have been here again today.
Thank you.
Okay, thank you.
I think we have,
We
your,
got paperwork
we have
to-
paperwork
okay.
to sign now,
All
and
right.
we can do that, so that you're very official.
Right. There you go.
You wanna sign here?
Okay. Don't want to sign in the wrong place.
I got a big yellow arrow.
Okay, okay. Cheryl's on top of all of this.
Here we go. That's yours.
And there's likely a doctor who'll get here who can help.
We appreciate all
Get a
your
little extra
attention
room
and
there.
all of that.
Yeah, I know.
EDD is always
It's becoming a bit of a tradition now for me to come down, so it's
Thank
quite
you.
all right.
Thank you, Judge, for taking the time to come down here. It's an honor to have you
Thank
here.
you, it's very kind of you to say.
Okay, thank you. Have you signed? We're married now.
I was about to ready for him to take you out.
Didn't know you were signing that.
I love it. $5.
Oh, it's my pleasure. Thank you. I will leave you to your meeting.
Oh, you don't want to stay? Come on.
I would, but
Thank you. Thank you, Angus.
Thank you.
Thank you.
Good. See you in a couple of years.
I'll be here.
Okay,
That's good to hear.
Yes.
Okay, back in the car he goes.
Well, next, we have the election of officers. This is the time of the year. We have a motion.
So I'm going to ask Dr. Stewart to present a slate of officers, and I will move for adoption of that.
I would propose and present to the board for the slate of officers for the year 2024 to 2025. As President of the Board of Directors, Mike Waltz. As First Vice President, William Nicholson. As Second Vice President, Jeannie Yee. As Treasurer, Bernard Stewart. As Secretary, Jacob Eatham.
Thank you, Dr. Stewart. Mr. President, I move that the Board of Directors approve the slate of officers as presented by Dr. Stewart.
I'll second that.
We need a vote.
Director Eapen?
Aye?
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? Aye. Director Stewart?
Aye.
Just want to thank Dr. Ethan for all that you have done today. Great job. Appreciate all of your assistance and support, and very much appreciate it.
Thank you. Thank you so much.
Yeah.
And trusting in me to shepherd all of you.
Well, it's going to be hard to follow you and Bernie. I hope we don't have any union people.
Me too.
Roy, so, all your backs.
Congratulations, Mike.
Oh,
Yeah.
We look forward to a wonderful 2025.
yeah.
Yeah.
And a very successful
Thanks.
parcel tax initiative. All right, well, where am I?
Thank you.
Here.
You put everything in the binders for everybody. So we're communication, and then
Yeah. Okay, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and on the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? All right, moving on. Are there any written communications, Cheryl?
No, there aren't written communication.
Thank you. All right, we are going to move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve the consent calendar items A through E?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar items A through E.
Second.
Thank you.
Director Eapen?
Aye.
Director Waller?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Thank you. Okay. We'll now move on to the presentations.
Yes, this evening we have Will Cobb, partner with PwC, and he is going to be presenting the annual audit results for fiscal year 2024. I'm going to turn it over to our Vice President and CFO, Tom McDonough, to do the introduction.
Thank you, Kimberly. Will is a partner at PwC Health Industries Group, based in San Francisco. Will has 26 years of experience serving clients primarily in the healthcare, nonprofit, and governmental industries. Will received his undergraduate and graduate degree from Auburn University. He is a certified public accountant and a member of the American Institute of Certified Public Accountants. Will has significant technical accounting and financial reporting experience related to healthcare, governmental, and not-for-profit entities. Will has extensive experience with bond offerings, affiliated foundation audits, FEMA program audits, and complex healthcare industry accounting and audit matters. Will has served as the district's external audit engagement partner since 2020. Welcome, Will, and we will turn it over to you for the presentation of the audit.
Thank you, Tom and Kimberly. Pleased to meet with everyone this evening, and with your permission, I'm going to share my screen. And can everybody see the presentation? Okay. So this is the time of year when we present the completion communications to you associated with the external audit, in this case for FY24. And I'm going to hit some highlights and perform the required communications. There's a number of required communications the professional standards obligate us to make to those charged with governance. And if you have questions or comments, please feel free to stop and we can have a conversation about any of those items or any questions that you may have. So in terms of the status of the audit, the audit is basically in the wrap-up phase, nearly complete. We're performing wrap-up, final tie-out procedures of the financial statements and disclosures, and what we refer to as keeping current, procedures, standard completion, timing-related procedures. And at the completion of that work, the audit opinion will be issued. And we anticipate issuing an unqualified or a clean opinion for the district for FY24 for the district and its related opinion units. As indicated here on the slide, there are no audit adjustments that have been identified for FY24. And we're able to communicate to you that we have identified no material weaknesses in internal control. There has been a lot of work that has been undertaken by your management team over the past year in marshaling the resources to support the audit process and prepare good financial reporting and enhancing the timing of the issuance of the financial statements. As you may recall, the last couple of years, the financial statements were issued in the following calendar year, and that will not be the case this year. And that's a testament to the hard work of management. And certainly we appreciate their support in satisfying all of our requests throughout the audit process. We recognize that these individuals already have day jobs. And so, supporting this audit process is, it can be cumbersome. And so that effort has not gone unnoticed from our part. And so just a shout out to a lot of effort from the management team. Really appreciate their cooperation throughout the process. We had in the previous year reported a significant deficiency in internal controls regarding account reconciliation, and happy to report that that item has been designated as remediated for FY24. And again, I confirm no material weaknesses there. There is one other deliverable that we complete for the district that'll happen in 2025. That's the OMB Uniform Guidance Compliance Audit. And as a reminder to the board, this is related to certain COVID-related funding, in this case, FEMA funding, and the district is required to have a federal compliance audit related to the compliance with the regulations regarding the use of those funds. And so that deadline for that audit is March 31st of 2025. And so we will be working to complete that audit prospectively. Lastly, on independence communications, happy to report we have no independence violations that we need to make you aware of. We are independent of the district and able to serve as your external auditor. Audit results, some of the required communications. We had previously communicated to you significant risks, and they're actually standard significant risks in either audits or audits of healthcare providers. The first is the management override of controls. This is considered a significant risk in all financial statement audits. Really goes back to the early 2000s and a number of the corporate frauds that had occurred, and the standard setting bodies, promulgated literature that requires us to perform certain procedures with respect to the risk of fraud. I say that as to not alarm you as to why this has been identified as a significant risk at the district. You can rest assured this is a significant risk at all organizations that receive financial statement audits. We noted no items with respect to the management override of control that we need to make you aware of. The second significant risk relates to the valuation of your patient accounts receivable. And I said this is sort of standard as well in the healthcare provider space, just due to the natural complexity of a healthcare provider patient receivables with third-party payers, with self-pay, with the estimation complexity that's involved there. It's considered that estimation of the values is considered a significant risk. And so, again, this should not be alarming to you that it's been identified. We see this in all our healthcare provider audits. We perform a number of procedures, especially with respect to subsequent collection of cash, both in the prior year to establish projections for how amounts are collected over time, and to establish that the district has a good history of valuing and collecting the amounts that are reported as net values. And then we also look at your subsequent cash collections here early in FY25 as it relates to your June 24 values. And what we found was that the amounts that have been recorded on the statement of net position at June 30th, 2024, both for the district as well as for the JV oncology component unit, are reasonably stated. This has a little bit more detail about the methods that we utilize to evaluate the values, the contractual adjustments that are reflected against those gross values to arrive at appropriate net values. But again, through the performance of all of these procedures, the amounts that were reflected at June 30 were determined to be appropriate. Another area where we have a required communication is in the area of significant estimates, not necessarily a significant risk, but as you know, the district has pension and post-employment plans, and the actuarial valuation processes therein represent significant estimates just due to the amounts and the complexities associated with deriving those estimates. The district utilizes outside actuaries to perform those valuations. We, in turn, utilize our own actuaries to assess the assumptions that have been selected and the actuarial methods that have been applied in deriving the estimates that are reflected in the financial statements. And we found those assumptions and those estimates to be reasonable. Other required communications, there's kind of a long list of required communications that we make to those charged with governance. I'm not going to read each of these, but what I can tell you is these are all the communications that you would want to see in terms of the responses. We received the full cooperation of management. We are not aware of any substantial doubt about the district's ability to continue as a going concern, not aware of instances of noncompliance with laws and regulations, and no significant difficulties encountered in the performance of the audit. We do have a reference to some supplemental materials, written material communications. For example, at the completion of the audit, management supplies us with a signed representation letter, and so that's considered a material communication. So we've included those materials. We've included our draft audit opinion, which will essentially have a signature added to it to make that finalized. And we've also included a link to our audit quality report, just to give you some comfort over the processes that we go through in terms of enhancing and self-monitoring and adhering to professional standards on quality for our profession. No instances of fraud, noncompliance. So that's really all I had. I'm going to stop sharing and would love to just turn it over back to you all if you have any questions or any items you'd like to discuss.
Any questions? Anyone? Nope. Thank you, Will. Thank you for your work. We really appreciate it.
Okay. Thank you.
Thank you, Will.
Yeah, I would like to just also thank Will and your team for all the work, and then also Tom McDonough, Melissa Garcia, and her team. I know that a lot of work that we set some expectations in terms of timing and putting in place written protocols and controls, and they've worked really hard this year, Melissa and her team, with oversight from Tom, and really want to thank everybody for all of that hard work. So thank you.
Thank you.
Thank you. Thank you, Will. At this point, we're going to take the action out of order, and can I get a motion to approve the audit report?
Yes, Mr. President, I move that the Board of Directors approve the annual audit report for fiscal year 2024 as presented.
Thank you.
Second.
Thank you. Sean.
Which one seconded?
Bernie.
Bernie? Okay, I heard both of them. Okay, Director Epen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
All right. Okay, thank you, Will. We're going to move on to the medical staff report. Dr. Sela. Good evening.
Good evening, everyone. Dr. Nicholson and Ms. Yee, congratulations on the new election. Job. All right. So for my report, the medical staff roster, we have a total of 656 members. Of those, about half, or 349, are active. 2 are administrative. 32 are advanced practice providers. 94 have ambulatory positions. 7 consulting. 13 courtesy. 2 are on leave of absence. 97 are provisional active. 13 are provisional advanced practice providers. 39 are provisional consulting. 7 are suspended currently, and 1 that has a temporary privilege. In terms of the medical staff itself, we had our medical staff luncheon, the holiday luncheon on December 6th, last Friday. That was well attended and enjoyed by many. We are looking forward to the new mobile MRI to be set up, and we're continuing to work on that. The aquablation program is ongoing, and I have did a couple of cases today, and I have a couple more next week. So that is continuing to be a successful program with good results. I think that's all I have, unless somebody has any questions.
Questions, anyone?
Thanks.
Okay. Well, thank you, Dr. Sela. Thank you. And, happy holidays.
You too. Good evening.
Thank you.
Good evening. Okay. Service League report.
Good evening, everyone. Warm greetings from all the volunteers. I'm pleased to report that in November, 206 Service League volunteers contributed a total of 1,839 hours across various hospital departments. 5 new volunteers have completed their training for the infusion center and radiation oncology department. They will soon be signing up for shifts, and we are excited to have them assist in these critical areas. Last week, the Service League hosted its semi-annual Masquerade $5 sale in the Anderson Auditorium for 3 days. Hundreds of employees and community members joined us to shop for the holidays. The sale was a great success, generating over $8,700 for the league. We'll be able to use this commission to support clinical care in the hospital. Many thanks go out to many of the volunteers whose hard work ensures the success of the sale. I would especially like to express my appreciation for Shri Gamardo, who is tireless in promoting and managing this fundraiser for us. So thank you, Shri. The gift shop also held a raffle during the sale with 5 lucky individuals winning exciting prizes. On Thursday, November 21st, we received a generous donation of 108 scarves and 34 baby blankets from the Girl Scouts and Walters Middle School Book Club. Their annual donation is greatly appreciated, and these donations will be given to patients to offer comfort during their hospital stays. On Saturday, November 23rd, we hosted an information session for 43 high school students. They received an overview of available volunteer opportunities and application requirements, and they were able to pick up applications to begin their process. On Saturday, December 7th, we held a well-attended orientation with 22 college students, 6 adults, and 1 high school student joining our team. Their enthusiasm highlights the continued interest in volunteering at Washington Hospital. And lastly, I'm very pleased to share that the Service League Board has voted to contribute $50,000 to the UCSF Washington Cancer Center campaign. This contribution reflects our ongoing support for the hospital and its mission to enhance care for our community. That concludes my presentation, and I'm happy to answer any questions you may have.
Questions, anyone?
Sheila, I just had a question of interest. The number of service hours the Service League is putting in, how does the present numbers compare to pre-COVID?
Well, it's picking up, Dr. Stewart. I think after COVID, people were just too afraid to come back and start volunteering. And I think we are slowly getting back to what we were before. It'll still take some more time, but we are, like everything else in the world, I think we are inching towards a more positive result as well. We are much better than when we had just opened up.
It's encouraging.
Yeah.
Thank you, Dr. Stewart. That's the first time I got an applause for that 50,000, and I thank you all very much.
Well, we thank you, and thank you for your leadership, Sheila.
Thank you, Mr. Wallace.
Sheila.
Okay, we're going to move on to quality report.
Yeah, we have Mary Beaumont, our Chief Quality Officer, that is joining us this evening to provide the quality dashboard for quarter ending September 2024.
Thank you, Kimberly. Yes, so this quarter is a reflection of quality data from July, August, and September, so quarter ending 9/24. Overall, we had a great quarter. I'm going to start with the infection prevention metrics. So starting off with our hospital-acquired MRSA, this is MRSA that's discovered in the blood 72 hours after admission to the hospital. We did have 2 MRSA bloodstream infections, so that's 1 more than expected in our comparison group. And as you can see, the quarter before we didn't have any, but we have had overall in the last year to a year and a half have had a couple spikes in MRSA. So because of that, we have implemented an MRSA prevention task force. And this is really a multidisciplinary multidisciplinary group. It's infection control coming in, working with physicians, ID physicians, frontline staff, and everybody's really come together and met frequently to address this issue of this spike in MRSA. And what we have done is implemented a couple of things. We started off by really looking at what is the current state on clinical best practice to prevent MRSA. So we went through, reevaluated all that, and then assessed what do we need to do to prevent it. And so a couple of the things, of course, always focusing on hand hygiene, which we're doing really well on right now. But it was more about looking into patients who arrive who might have MRSA that is just colonized in their nose. We're now starting some decolonization, so that way the patient doesn't have to worry about when they're in the hospital and they become sick. Sometimes that MRSA can turn into an active infection. So we're starting some decolonization practices with the ID staff, and I think that that will also help. And we're also doing things at the bedside with process. And all patients now, especially in high-risk units, are having chlorhexidine baths every single day. This keeps the skin free from MRSA, especially when it's done consistently. Done a lot of training with the staff, and like I said, we've had a lot of great frontline engagement. And as a result, we have not had an MRSA infection in 75 days. These infections that you see obviously were earlier, they were in July. So it looks like it's working well, and we'll continue to work with this task force to see if we can get into sustaining for prevention of MRSA. And then moving into our catheter-associated urinary tract infections, as you all are aware, we had a great sustained phase of not having CAUTI. This last quarter, we did have another CAUTI. This puts us basically right at our benchmark. They expect about 1 CAUTI in our comparison group, but we still take that 1 CAUTI seriously. And one of the things that we're really looking at here again is, since we had one the quarter before, is focusing on 3 aspects of preventing CAUTI, which is the catheter medically necessary? Does the patient really need it, is one thing. And our medical staff works really well with us on ensuring that, using nursing-driven protocols, and making sure that our catheters are properly inserted and maintained. Most of these that we've had, we've only had 2, so recently, have been after the catheter was placed, a few days after. So it didn't look like it was something related to insertion. And so we're focusing on maintenance practices. And then, of course, lastly, the last intervention we're focusing on is removing the catheter when it's no longer medically necessary. And so those are real stringent practices. Again, have a lot of support all the way from senior leadership to frontline clinical staff on making sure that we get these back down to 0. Moving on to our central line infections, we're very happy to report that we've continued to sustain this. And here now we are all the way in December. And again, this report only goes through the end of September. But right now we're at 939 days without eclampsia. So this is a significant achievement and very reflective of magnet status in the hospital. 939 days of patients avoiding preventable harm and not having to deal with central line infection. So again, it's a reflection of them being inserted correctly. We don't use too many here. We use less than expected. That's huge in keeping down your central line infections. And when we do have to put them in place, we're maintaining them very well. We can confidently say that with this long sustained period of no eclampsia. And then moving into our surgical site infections, this is the colon surgery, high risk surgery for getting infected, which of course is why on a federal and a state level, we are mandated to report this out. And we've again sustained 0 in surgical site infections with these colon surgeries that we follow for 30 days after discharge. And this is really good reflection of surgical practices in the OR, turnover, cleaning, right, everybody who's involved in that team, and education to patients prior to discharge, et cetera. Great outcome. And we've seen a similar one in our next slide for surgical site infections on hysterectomies. which is 0. Again, very well sustained, same thing. Could be a high-risk procedure for surgical site infections, also mandated reporting on a federal and state level, and continuing to see this sustained. And so this is also a good reflection of the same practices that we're seeing that keeps our colon infections, our colon surgeries from not being infected. C. diff is something that we're also very proud to report. We only had 2 infections this last quarter, expected to have closer to 9. This is something that we've really sustained well, and it's really a reflection of the entire clinical team working together and preventing the C. diff when a patient comes in. If we know that they have any history of C. diff or they're having, loose stools for a certain period of time, we test right away. And if the patient turns out positive for C. diff after 72 hours of admission, the hospital owns it, regardless of any clinical diagnosis. It's what they call lab monitoring hospital-associated infections. So there isn't a lot of clinical aspects that the CDC looks at with these. They just want to know, does the patient test positive 72 hours after admission? And if so, we own the C. diff. But for these 2 cases that we had, we do a root cause analysis, and there was some opportunity for improvement on maybe testing earlier. So I'm very confident that these are actually community-associated C. diff infections because the patients were symptomatic prior, and then we just happened to test afterwards. So again, lots of engagement from the unit level on looking at, what we can do to improve documentation and know when to test these patients more proactively. But again, I don't think that this was something transmission-based, which would be a bigger concern for us. Hand hygiene, as I mentioned prior, we continue to do very well in this. We're at a 98% compliance. The goal is 90%, so we're really high up on this. And this is actually a reflection of over 7,189 encounters is what this is over a quarter. This is real true engagement on a unit level where the staff are meeting their goals on how many hand hygiene observations they have to do. They have an electronic web system they use. It makes it nice and easy to document, gets right to infection control, and our patient safety officer, Kristen, has worked really closely with the infection prevention team and the units to make sure that we're getting a large volume to look at. And as you can see, this is a great result at having 98% compliance. It is the best way to prevent the spread of infection and prevent hospital-associated infections. So this is another good outcome. And our other nursing sensitive indicators, looking at patients that fall in the hospital, is just defined as an unplanned descent to the floor. We have had really good luck with this and good outcomes with this on not having problems with meeting the benchmark. This has been sustained for over a year and a half. This is a reflection of actually there are 5 falls in this, but we're still below our benchmark. This is over a quarter. These were minimal abrasion injuries, no major injuries to this, and again, keeping us well below the benchmark. Where we place our patients is very important. We're very strict about patients that are at high fall risk being placed near the nursing station, frequent rounds. It's not just a CNA's responsibility, it's anybody's responsibility who walks past the room and there's a call light on to go on and see if the patient needs something, because most of these occur when patients are trying to get up and use the restroom and are used to having independence at home and then come into the hospital and are a little bit disoriented. And all of these are in patients over 70, or I think we had actually one younger patient with this, but again, high risk for falls. And so we're happy to report that that remains under the benchmark. Then moving into our pressure ulcers, which are otherwise known as bed sores. Again, we've been able to do point prevalence studies, which is where a group of trained nurses go around and they pick a day in the quarter and they look at the patients directly they do a direct skin assessment of the patients. It's a very thorough skin assessment. They looked at 134 over this quarter, and this is 0. They did not find any pressure ulcers, and so we're well below the benchmark. The national rate's about 1.45%, and we were at 0. So there's a couple things that can lead to an outcome like this, which is using the right beds for our patients, having really good quality mattresses, turning over rotating patients as they need to if they don't have the mobility to do it themselves, monitoring nutrition carefully, and assessing their skin and their risk factors on the day of admission, which is done really well here by our nursing staff. Moving into readmissions, the good news about readmissions is it's all heading in the right direction. We still have a couple areas that are challenges for us, but starting off with heart attack, otherwise known as AMIs. We only had 1 patient come back in this quarter out of 17, puts us at a readmission rate of 5.9%. CMS on the national level expects this to be around 14.6%. So this is a population that we're doing well on, and this has been heading in the downward trend for the 3rd quarter now. This is a group of patients that when we looked at these 17, they had a primary diagnosis of a heart attack, they were in a little bit of a less complex group because we were trying to figure out why this is heading in a good direction, and is there anything that we can apply to the other populations. One of the things that we did notice is that this quarter had less comorbidities. And that's different when you move into the next group, which is pneumonia. So for pneumonia, our 30-day readmission rate was 16.3%, just ever so slightly about 1 patient too high because the benchmark is 15.3%. So 7 patients came back out of 43 with pneumonia. These 7 patients were all very ill. Most of them were greater than 85. 3 of them are in their 90s. We're very lucky to have Dr. Akawili, who does 100% chart review on all of these patients. And as you're aware of, she's got a long career working as an intensivist and has a very strong clinical background in medicine. And she's looked at these patients very thoroughly, and they had a great deal of comorbidities. Some of them are even eligible and probably would have benefited from maybe even some palliative care referrals and potentially even a hospice referral. So we're looking into really continuing to build those relationships with those programs in the hospital, getting them in front of patients and their family members early on in their index stay, and discussing plan of care, a long-term plan of care. And then when we move into heart failure, again, another group of patients that are very chronically ill. This quarter, we had 6 patients come back out of 34. Gives us a readmission rate of 17.6%. I'm happy to report that is lower than, but only slightly lower than the 18.8%. So these 6 patients also were very similar in Dr. Akawili's review is what we're seeing with the pneumonia patients. Majority of these patients were over 85. One difference we did notice in this group was we had a high return rate from our skilled nursing facility. It's very important that when patients are transferred from acute care into any other setting, but especially another level of care such as skilled nursing facility, that we're all on the same page with the plan of care. And so Dr. Akawili's working with the medical directors at the SNFs that we use in this area and making sure that they are using the most current clinical bundle practices for managing heart failure and pneumonia when a patient's in a skilled nursing facility, that they're communicating with us. We have a transitional care program coordinator, Emmanuel, who I've mentioned here before in the past, and he's working closely from an administrative side on, holding the skilled nursing facilities accountable to making sure that these patients are getting the quality of care they need while they're in the skilled nursing facility so that they don't have to return to an acute care setting. This is something we'll continue to develop further in 2025 also. COPD is very similar process there that we're using with pneumonia and it's basically this quarter we had 4 patients come back, gives us a rate of 20%. That is, of course, higher than what CMS expects, which is 18%. It's a small group of patients. We only had 20 discharges. This was also the 4 patients were all over 80. We did have one 90-year-old in here. These are patients also that are being recommended for looking at long-term care plans related to potentially palliative care in these 4 cases. And we did not have an issue with patients coming back from skilled nursing facility in this. This was more about going home, understanding the plan when the patient got home, making sure that they're using their medications and getting an early visit to the doctor. This is key in any of these readmission populations. But for these, 2 of them did actually have an appointment made, but then did not get there. And Emmanuel's working really closely with these patients in all across these groups, actually, to make sure that he calls them within 3 days of discharge and that they are aware of what their plan is. They have a plan for getting to the doctor. We're starting to look into offering transportation for the patients if they can't. It's a lot of them, especially the elderly population, some of them, aren't driving anymore or their spouse isn't driving anymore. And so we want to be able to offer them extra support to make sure that they get in to see their primary care doctor. That is probably one of the best interventions we can do to prevent patients from having to come back to the acute care setting based on the literature that we've reviewed. And then moving into our surgeries, coronary artery bypass graft, otherwise known as CABG. So when we look at these patients, we were just looking at an inpatient population who came in and had a CABG. We did not have any patients come back. There were only 3 to begin with, and luckily none of them came back. The transitional care plans were good, and all of these patients actually went home and didn't suffer any complications or decline. So they were able to stay out of acute care. Moving into our next one, which is our inpatient elective primary total hips and knees. This group is inpatient only, what you're seeing. So there's only 14 patients in this quarter that had an inpatient surgery, meaning that they spent at least 2 midnights in the hospital. And out of the 14, we had 0 come back. And what's good about this is even though it's a small group of patients, the national benchmark is about 5%. It's a little bit higher than what we expect for our outpatients who have this procedure, because obviously if you're inpatient now, the standard is that the patient is typically sicker. They have something else that we're worried about may complicate after they have their surgery. So we watch them closer and keep them in the hospital for a couple of days. Diabetes, hypertension, things like that. And for these 14 patients, there were no issues related to that. And then if you move into the next slide, for our outpatients who had the same surgeries, which are hip and knee replacements, a much larger volume, of course, 330 patients had this procedure in this quarter, and only 2 of those patients came back, giving us a really small readmission rate of 0.6%, which is lower than the 5.1% that CMS expects. And these 2 patients did come back, but totally unrelated to the surgeries. They met medical necessity and needed to come back, and they had short admissions and then were discharged home. So overall, it's still a great outcome for that volume of surgery, that these patients get such good care and have such good upfront planning on this elective procedure that they very rarely have complications or have to come back to the hospital. And that concludes my report. I'm happy to answer any questions.
I would say that you gave a very splendid report, kind of a nice gift during the holidays to us. I compliment you on that. Any questions?
Please thank your team for all the hard work.
Yeah, Mary, this is Bill. I've got a couple of questions. Number one, on C. diff, I get the sense that we still have a fair amount of C. diff in the community. I know it's not reportable in the outpatient environment, only the facilities need to report that. But do we have any way of garnering more information as far as how much C. diff is happening within our community? what this really comes down to is making patients aware of the risk of C. diff with respect to prescribing antibiotics unnecessarily. This is a constant educational, I'll say an uphill climb that I have to do with many patients, is to tell them why they don't need an antibiotic and why there are risks associated with an antibiotic. So my question is how do we get a better handle as far as what the C. diff rate is in the general community? Any suggestions there?
I know that's a good question. I think, and you're absolutely right that it's really a reflection. Ultimately, it's an outcome of antimicrobial stewardship in your hospital and, in the general sense of the community. But because it's not reportable to the county anymore and not to the state, the epidemiology around it is not clear and is not public. But one of the things, because right now it's only mandatory reporting on the inpatient setting. But one thing that I think we could do, there are groups that work within CDPH that have some sense of like endemic C. diff, MRSA, things like that. I can look into the state and see if they have any way of giving us any updated literature on that. The literature that we have that we get through CDC is, of course, much more on a federal level. That gives us, some sense of it that's reported through labs and things like that. But I can look into CDPH. It's something that Dr. Martin and I, have had many discussions about over the years too. What makes it, sort of go up? And as you can see, even for our hospital size and type, they still expected us to have even 9 infections, which seems like a lot for that period of time. We know it's definitely around a lot, but I don't have exact figures for Alameda County.
The only thing that comes to mind for me that where we could get a handle on monitoring it is vancomycin has now replaced metronidazole or Flagyl as the treatment of choice, or first-line treatment for C. diff. And pretty much oral vancomycin, the only reason we use that is in C. diff. So if we could find the number of oral vanco prescriptions which are being prescribed at the local pharmacies, that might give us some idea. I don't know if there's any way of getting that kind of data.
I think there may be. Yeah.
All right. The better we understand this as far as what's happening out in the community, the better we'll be able to deal with the patients who might come in with C. diff. And if we don't recognize it early, then we get labeled as a hospital-related C. diff.
Absolutely.
The other question I have is respect to those high-risk readmission patients. And I'm thinking of heart failure and COPD, where there are a lot of expensive medications which are being prescribed. Many of these are non-generic medications. The inhalers are very expensive for the patients. So the question I have is, what do we have ongoing to monitor whether patients following discharge have actually gotten their prescriptions filled? And if not, have an action plan to, assist them to get, those expensive brand name medications, which often the pharmacy benefit managers, the PBMs, put obstruction in the way of patients getting those medications on an easy basis.
Absolutely right. Access to the medications is, and this is one of the reasons why equitable care is such a hot topic right now, right? Because that is a huge part of the problem, is that if these patients don't have access to it and then eventually you're not taking it and then come back to the hospital because they get sick as a result. I can tell you specifically what we do at Washington Hospital is this follow-up phone call is really important, because we of course have the med rec process that happens in acute care, and our pharmacy is Our pharmacy team is very engaged on going over the medications with the patient, using the after visit summary, trying to work with the family, discussing how medications are going to get filled. All of that in the acute care side at the bedside before they leave happens well. But then the question is, what are they actually doing when they leave? And so Emmanuel has, 100% compliance rate on calling these patients, with especially pneumonia is our priority one. And then I would probably say heart failure and then COPD, but he is calling on a lot of them. And one of those patients that was in there actually as a readmission, it did not pick up their medication. It wasn't because of an expense related. It was just they needed to take 3 more days of antibiotics for the pneumonia. And it was just a misunderstanding of they thought they had enough in the when they got their IV antibiotics. And then there was just a misunderstanding about what was supposed to be picked up and including which pharmacy they were supposed to pick it up from. So communication is essential, and it is very important that it happens. Again, afterwards, it needs to happen within about 3 days of discharge. If you even wait any longer than that to make your follow-up phone call, the patient's risk for coming back dramatically increases. And you have to have somebody on that call who's competent enough to talk to patients about the importance of their medications, accessibility. So when Emmanuel identifies a barrier in that, we look at how can we get the patient the medication. And, you mentioned probably one of the biggest barriers, which is economic factors to accessing these medications. So there are charitable guidelines that we work within here at the hospital, where if the patient meets for not having a payer source, then we are able to get a charitable source, and we are able to cover the medications for the patient when we can, and when it meets, compliance guidelines for doing that for patients. And so that's one of the things we've done, but it's really communication, like I said, and making sure that the families understand. Because, we know they don't remember and hear a lot of what we say while they're in acute care, because it's such a difficult time to remember all the things you're hearing from everybody in the healthcare on the front line.
Thank you, Mary. I think it's something we clearly need to work on and to help avoid those avoidable readmissions.
Yeah, medication's one of the biggest factors that brings people back.
Thank you.
Thank you.
Thank you, Mary. Thank you, Bill. Thank you for the conversation. Very good. Thank you. Okay, we're going to move on.
Yes. Now moving on to the financials and the finance report by for October. Yes.
Okay, I'm going to present the final operational performance of the hospital for October 2024. Inpatient average daily census was 156.8 on a budget of 170. On a year-to-date basis, we're at 154.4 on a budget of 168.3. Discharges were 984 on a budget of 1,012, or about a 2.5% shortfall. And on a year-to-date basis, we're at about 1.5% at 3,800 versus a budget of 3,850. Patient days for the month of October were 4,860 on a budget of 5,269. On a year-to-date basis, we're at 19,000 versus a budget of 20,700. Observation equivalent days are 5% better than budget at 401 versus a budget of 420. And on a year-to-date basis, we are also 5% better than budget, outperforming by 87 outpatient equivalent. Average length of stay for the month of October was 5.15 on a budget of 521, so outperformance there by 6 basis points. And on a year-to-date basis, we stand at 5.2 on a budget of 5.38, or 18 basis points of outperformance. Our case mix index, CMI, for the month of October was 1.6 on a budget of 1.587. And on a year-to-date basis, we're at 1.627 on a budget of 1.584, or about 43 basis points. Deliveries in the month of October totaled 135 on a budget of 133. And on a year-to-date basis, we are outperforming the budget of 514 by 36, at 550. Surgical cases came in almost on budget at 548 to a budget of 550. And on a year-to-date basis, we're outperforming by 19 surgical cases. Cath lab in the month of October came in at 219 on a budget of 198. And on a year-to-date basis, we're at 774 on a budget of 769. Outpatient visits, 9,500 on a budget of 9,400. There's some outperformance there. And then on a year-to-date basis, we're outperforming by 527 days at 35,850. Emergency visits in the month of October totaled 5,100 on a budget of 5,600. And on a year-to-date basis, we're off by about 6% on budget at 20,297. So I'm just going to highlight a couple. Orthopedic cases were strong at 221 on a budget of 201. And endoscopy was also over budget at 132 on a budget of 118. In the cath lab, cardiac outperformed at 129 versus a budget of 94. 35. Moving on to operating indicators, from a productivity standpoint, productive FTEs were better than budget by 87.2, and non-productive FTEs were off budget by 10.6, bringing our total FTEs under budget at 76.6 FTEs. FTEs per adjusted occupied bed in the month of October came in at 5.94 on a budget of 5.86. So slight trailing there. And on a year-to-date basis, through October, we're at 6.05 on a budget of 599. So 6.6. Moving into deductions, the third line, contractual as a percent of revenue.
What's that audio?
Was 75.21 for the month on a budget of 75.22. And on a year-to-date basis, we're at 75.19 on a budget of 75.21. When we look at provision for provision as a percent of revenue, bad debt and charity, we're at 1.73% for the month of October on a budget of 184 for 11 basis points of outperformance. And on a year-to-date basis, we're performing 19 basis points better at 1.65 versus 1.84. And then finally, the aggregation is 76.94% on a budget of 77.06 for the month of October, and for the year, 76.84 versus a budget of 77.05 for 21 basis points of outperformance. So moving into the financials and the GASB format, gross patient revenue came in at $222,494,000 on a budget of $221,100,000. Moving into the net operating income, $1,162,000 on a budget of $808,000, so outperformance of $350,000 for the month of October on NOI. On a year-to-date basis, we stand at 1.25 on a budget of 366, so outperformance by almost $900,000 on net operating income. Moving down to non-op, the non-operating income came in at a negative 131 on a budget of 835,000. On a year-to-date basis, we stand at 7 million versus a budget of 2.5, so outperformance by 4.5. Bringing net income for the month of October, $1,031,000 on a budget of 1.6 612,000 trailing. But on a year-to-date basis, we stand at 8.2 million on a budget of 2.8 million, so about 5.4 million is outperformance of net income on a year-to-date basis. Switching to the FASB format, net operating income in the month of October would have been reported at 667,000 on a budget of 179,000. And on a year-to-date basis, net operating income would show 819,000 versus a budget of negative 2.15, so outperforming $1.3 million. Moving down to net income, second from the bottom. For the month of October, we came in at 1.7 million on a budget of 1.3 million. And for year-to-date, we stand at 2.8 versus a budget of 1.4, so 1.4 million of outperformance under FASB. Moving back into GASB, but on the EBITDA, earnings before interest, depreciation, and amortization, line 5, for the month of October, EBITDA came in at 4,544,000 on a budget of 4,290,000, so outperformance of about 6%. And on a year-to-date basis, we stand at 14,872,000 on a budget of 14,255,000, so about $620,000 of outperformance, or about 4.3%. And with that, Chair, I conclude the report.
Thank you. Tom, thank you. Any questions?
Yeah, Tom, we still have that overage on the GASB property tax. Is that going to get?
It will not normalize in this fiscal year.
That was my question, okay.
So the September 23 GO bonds represent 85% of that 800 and some thousand variance, and then because it is a assessment on the properties, because those change from being assessed to not being assessed for whatever reason, the dollar value does change periodically, but the bulk of that change is the GO bonds that we did in September.
Okay.
And so it will normalize in fiscal 26.
So we're going to be hurting then. Is that right?
Well, we'll put in a budget of this number.
Okay, all right.
We'll be on track.
All right.
So does that answer your question from before?
Yeah.
Thank you.
Thank you. Okay.
All right, I will now present the November preliminary operations report, and starting with the total gross revenue. Patient gross revenue of $221.2 million for November was favorable to the budget of $219.5 million by 0.8% and higher than November of 2023 by $30.5 million or 16%. Looking at year-to-date revenue, it was favorable to the budget by $11.3 million and favorable to last year to date of $122.1 million. Going on to our trauma cases, we had 158 trauma cases for November, which was favorable to the budget of 113 by 43 or 38.9%, and year-to-date we were favorable to the budget by 40.2%. Again, as I've mentioned in the past, inpatient trauma cases have been unfavorable to the budget. This month they came in at 48 compared to a budget of 73, and that's about 34.2%. That our outpatient trauma cases of 110 for November were favorable to the budget of 40 by 68 or 172.5%. And we did talk with some of the consultants that had worked with us, and a lot of the trauma centers are seeing less inpatient cases and more on the outpatient side of things too. So they feel what we're seeing is a normal trend from that standpoint. Trauma cases for November, moving on to by activation code, yes, a total of 158. They were broken down. We did see the most alpha number of cases this month, and this is the most severe trauma cases, followed by 47 Bravo cases and 98 Delta cases. You can see year-to-date, we have 47 alpha cases, 244 Bravo, and 456 Delta. Just in terms of the types of cases that we saw in the month, 61 were falls, 27 motor vehicle crashes, and 8 body injuries and others, and 62 other cases. Looking at our gross revenue, trauma gross revenue of $17.3 million for November was favorable to the budget of $14.5 million by 18.7%, and year-to-date revenue was favorable to the budget by $9.5 million or 14%. Again, looking at inpatient trauma gross revenue of $12.3 million for November was unfavorable to the budget of $12.9 million by just $0.6 million or 5%. So the cases we are seeing as an inpatient are more acute than we had originally thought too. So because revenue per case for inpatient is $79,000 higher than budget. And then outpatient trauma gross revenue of $5 million for November was favorable to the budget of $1.7 million by $3.4 million.
Do we have any information on payer mix for our trauma patients?
We do, yes,
Okay.
and so we can break that down and provide that information. And just it does take time because as I said before, a lot of our cases, especially motor vehicle accidents, come in as self-pay, and then as they sort of work through the system that way. But yes, I can provide an overview of the payer mix. Yeah, so. We're working on doing that whole overview.
Yeah, I think that's going to have a longer lead time.
Yes, it does, to get all the accurate, yes, it is. All right, moving on to the inpatient gross revenue of $134.2 million was favorable to budget by $3.9 million and $25.9 million higher than November of 2023. Really seeing favorability in November mainly in surgical services, cath lab, and emergency room, and a little bit from the birthing center. Looking at outpatient gross revenue, it came in at $87 million, which was unfavorable to the budget by $2.3 million and $4.6 million, or 5.6% higher than November of 2023. So we did see a little bit less compared to budget this month. Looking at our average length of stay, we continue to see improvements in this. It came in at 5, which was favorable to the budget of 5.21 by 4.3%, and the average length of stay was lower than the November 2023 average length of stay of 5.07. Looking at our inpatient daily census, came in at 168.8, which was unfavorable to the budget of 178.3 by 9.4 or 5.3%, but was higher than the November 2023 average daily census of 156.1. And again, some of this is due to, we saw lower telemetry in adult med surge, but also because of the less inpatient trauma cases than what we had budgeted. We saw 25 less cases than what we had budgeted. Looking at our discharge trend, again, November discharges of 877 were unfavorable to the budget of 1,026 by 149, of 14.5%. Year-to-date discharges were unfavorable to the budget by 203 or 4.2%. I will say we did have some patients still remaining in-house that were over 30 days, that around 7, but we were down to 2 now in December. So we did work to do that, but we did see a little bit of an increase in that. Looking at our patient days trend, patient days of 5,065 were unfavorable to the budget of 5,318 by 252 days or 4.7%, but were 8.9% more than November of 2023. Again, we had about 107 less trauma days than what were budgeted, and again, and also with seeing a lower length of average daily census too, and length of stay, that also brings down the patient days. So it's not necessarily always negative in terms of that overall. Moving on to our surgical trend. Total surgeries in November of 511 were unfavorable to the budget of 538 by 27, or 5%, and were 54 more than November of 2023. Year-to-date, cases were unfavorable to budget by just 11, or just slightly unfavorable to budget by 11. Inpatient surgeries of 265 were unfavorable to the budget by 5, and outpatient surgeries of 246 were unfavorable to the budget by 12. So moving on to look at the breakdown of our surgical activity. As you can see, orthopedics, so we had another strong month. We had 206 cases versus a budget of 193. 15 of those cases, orthopedic cases, were trauma cases. We did have the UCSF ortho trauma surgeons did perform 63 cases this month. You can also see total number of trauma surgical cases for the month was 25. We did see 8 less neurosurgery cases and 11 less vascular cases. We did have one of our vascular surgeons that was out for a number of days this month. And then the other area, other surgery, was down by 42 cases. Some of this was general surgery, also urology, and across a couple of other areas too. Moving on to the cath lab, we saw November cath lab cases of 190 were unfavorable to the budget by 20 or 9.5%, but were 40 or 26.7% more than November of 2023. Cath lab inpatient cases of 112 were unfavorable to the budget by 10, and outpatient cath lab cases of 78 were unfavorable to the budget by 10 also. The next page gives a breakdown of our cath lab activity. You can see in total we had 3 trauma cases that came to the cath lab. We did see less cardiac cases. We did have a couple of our community physicians had taken a little bit more time off in terms of the cardiac side of things. Also, non-vascular cases, we were down by 18, but our peripheral vascular cases were up by 5, and also you can see we had another strong month of neuro-IR cases that were up by 7. Moving on to deliveries. Deliveries came in for November at 126. They were unfavorable to the budget by 8, but were 10 more than what we saw in November of 2023. Year to date, deliveries were favorable to the budget by 26 or 4%, and also favorable to last year by 8.2%. We also saw our C-section rate was 24.6%, and this is the lowest that we've seen in a number of months in terms of it. So I know that our team is working on a number of initiatives that are just starting to roll out in terms of it. Looking at our non-emergency department outpatient trend, visits came in at 8,065. They were unfavorable to the budget by 731 or 8.3%, and fewer than November of 2023 by 7.6%. There were 2 main areas that were driving being below budget. The first is in lab, and that came in below budget by 9.1%. And also our cardiac rehab visits came in under budget by 11%. And cardiac rehab visits, we were definitely having some staffing challenges that we are working through with that right now. Moving on to our emergency department trends, you can see that we came in at 5,029 visits. It was unfavorable to the budget by 320 or 6%, but were 137 or 2.8% more than the prior year. As I think I've mentioned in the past, we are not seeing as many of the lower level visits in the emergency room than what we had budgeted, and so that's really what's driving it in terms of being below budget.
And these numbers are separate from trauma?
No, they include the trauma.
Okay.
Yep. It's not as high as budgeted, but we're still seeing compared to last year higher visits. Yeah. Looking at our gross revenue recap for November of 2024. Our surgical services revenue was favorable to budget by $3.5 million or 8.6%, and really this is due to the mix of the cases that we saw. As you saw, we had over budget in cardiac and ortho cases in particular, and neuro-IR cases. Neuro-IR is in the cath lab, sorry.
Yeah.
Cath lab revenue was $1.9 million, or 17.5% favorable to budget, and cases were 20 or 9.5% unfavorable to the budget. And again, that's with the mix of the cases. You can also see room and board came under budget by 2.5%, and again, we had less patient days, which is also driving some of the ancillary services. But our emergency department came in at 13.4% in terms of over budget, in terms of gross revenue at close to $2 million over, and again, a lot of that had to do with our trauma cases too. Moving on to our preliminary payer mix for November, government-sponsored payers made up 73.3% of total gross revenue. This was favorable to the fiscal year 25 budget of 74.5%. You will see that Medicare was down, but Medi-Cal patients was higher. They came in higher at 24.3% compared to 20.5%. Most of these cases came through the emergency room, what we're looking at. HMO gross revenue was HMO came in at 3.1% compared to a budget of 1.7%, which was favorable to budget. Then you can see PPO came in at 19.8% compared to 20.9%. So that was unfavorable to the budget. And as I mentioned, self-pay did come in higher at 2.6%, but again, we're really continuing to look at that number, and it does change. And I believe Tom did tell me at this point it's already come down to about 2.1%. Yeah, so close to budget. Moving on to our productivity indicators, our productive FTEs for November, adjusting for volume, came in at 2.1% favorable to the flex budget. Then moving on to the non-productive FTEs, they were also came in under budget at 33.1% favorable, and they came in at 177 FTEs. And looking at our total FTEs and adjusting for volume for November, we're 89 or 5.4% favorable to the flex budget. They came in at 1,464. So total FTEs per adjusted occupied bed of 5.9 was unfavorable to the budget of 5.76 by 2.4%. So we did have a busy month in November. Moving on to radiation oncology, you can see our treatments in November were 365 or 41 cases or 13% favorable to the budget of 324, and 91 cases or 33.2% higher than November of 2023. I do just want to note that the budget is lower this month because there were 3 holidays for the UCSF physicians to Veterans Day, Thanksgiving, and the day after. Yes. And year-to-date November treatments were 1,736 or 8.1% unfavorable to the year-to-date budget. Looking at our new patient referrals and new patients seen in the clinic, in November we received 26 new referrals that came in from various sources, and also we saw 22 new patients seen in the clinic. Our conversion rate for November at this point is 30.8%, so 8 converted. This is higher than what we've been seeing, and as you know, they still continue to convert as they go through the process of seeing other physicians and getting biopsies too. Moving on to Whitmith. Whitmith clinic visits for November came in at 14,893. They were unfavorable to the budget in November by 711 or 4.6%. This was primarily due to primary care, which was 9% below budget. We do have an opening in Warm Springs Clinic, and so visits were down 27% because we do have that opening. We also had a few physicians take some additional days off than what were budgeted. Our specialty care visits, though, were favorable to the budget by 0.4%. We did see increases in women's health, gastroenterology, and neurosurgery. All right, moving on to preliminary outpatient statistics for Development Corporation. Outpatient visits came in at 2,195. They were favorable to the budget by 153 or 7.5%. And for November, they were also 10.6% more than the prior year. For Washington Outpatient Rehab, visits were favorable to budget by 9.6%. For Washington Outpatient Surgery cases, cases were favorable to budget by 5.9%. Peninsula Surgery Center was down by 15 cases or 16.3%. We had budgeted for Dr. McDonald to start earlier. He just started. He has joined Dr. Dearborn. He's another orthopedic joint surgeon who just started this in November. So we'll start seeing some. He started doing cases in the beginning of December. Yeah. All right, lastly, days cash on hand for November ended at 119 days. It was a decrease of 4 days from the prior month. This is mainly driven by doing our $8.2 million in IGT contributions. If you remember, this is our one that we have to send in, and then in January, Tom was just telling us that we should be receiving back around $21 million. So in terms of it, so that includes that $8 million. So there's another $13 million in terms of additional funding that we should. But this is part of that intergovernmental transfer that we have to do. And that is the presentation for November. Any questions? In January?
Okay.
Probably towards the end if I know the government. Yes.
The trauma surgeons, when they're on call, is this for trauma or is it for general whole surgery?
They do both acute care general surgery and trauma surgery, so they do both. Yeah. Yeah. So they'll come in, and that's why they also have a backup. So there's always two trauma, if that's probably what your question was, there's always a backup that has to be very much readily available. And I do believe if they're going into a case, that they're letting the backup know that they're going into a case. So, yep.
Well.
All right, I'll move on to the next. I would like to introduce our Employee of the Month for December, Ramela Bayard. He's Environmental Services aide. And whether working directly with Ramela or observing him in action, his dedication and kindness are clearly apparent. Ramela joined our healthcare system family 5 years ago in the Environmental Services Department. Unlike some of his colleagues, Ramela enjoys working nights and especially in the emergency department. Through his work, he interacts both with members of our nursing staff and our patients. His manager, Brian Fell, says, Ramela is an outstanding example of someone who has earned Employee of the Month recognition. We frequently receive positive feedback complimenting his work ethic. He recently accepted a temporary role in the outpatient lab. Though the lab opens at 7 a.m., Ramela's shift originally was to begin at 7:30, when he noticed that much work was being done between 7 and 7:30. He requested that his start time begin earlier so that he was more comfortable being busy than not.
Yeah.
His work ethic began in the Philippines, where he worked as a head waiter at a prestigious restaurant. He then relocated to New York City, where he worked for 13 years for the famous fashion designer Jeffrey Bean. When needs of his family brought him to California, he wanted a role that would benefit from his gentle manner and strong work ethic. His cousin works for Washington Hospital and encouraged him to apply. Once brought on board, Ramela discovered many ways to embrace our patient-first ethic and contribute to the care of our patients. We congratulate him as our December Employee of the Month.
Somebody who likes to work.
Yes, he likes to be busy.
Yeah.
Emergency room, as we know, is very busy, I know,
Yeah.
especially. All right, so I'm going to move on to our past health promotion and community outreach events. We had a few in November, as you can see, and they really focused around with our trauma teams, Stop the Bleed training and blood pressure stroke checks and stroke education that we did both on November 17th and November 18th. November 19th, our spiritual care coordinator, J.B. Goodyear, spoke about holiday grief and grieving at the Masonic Homes. Then you can see on November 20th, Dr. Dearborn, our orthopedic surgeon, spoke about safely home after hip replacement and had over 600 views on both Facebook and YouTube. And then also on November 20th, we had Diabetes Education hosted a booth at the Afghan Coalition Health Fair in the Fremont Downtown Event Center. Moving on, November 29th, we did participate, and I know there's some pictures, at the Niles Festival of Lights Parade. December 4th, Dr. Kumar talked about grief, coping with grief and bereavement on Facebook and YouTube, close to 300 views. Also, December 5th, we had diabetes management presentation at Thermo Fisher, and I know all of us participated in the annual holiday tree lighting at Washington West, and we had about 150 attendees. Lastly, there was also a tree lighting ceremony at Newark. Quite a few people there. You can see some of the pictures. Wadwara. Just mentioning, we do have two health promotion and upcoming outreach events. We will be hosting on December 12th a nutrition education booth at Thornton Middle School Wellness Fair, and then on the 18th, Dr. Prasad Kata, endocrinologist with Washington Township Medical Foundation, will be talking about disease management, how GLP-1 medications work on YouTube. And then lastly, just in terms of the Healthcare Foundation, we talked about the tree lighting. I do want to thank everybody that participated on December 3rd. In Giving Tuesday, we raised over $8,000 for the UCSF Washington Cancer Campaign. I know Sarah Gemsky just let me know that we have raised now over $11 million towards our goal, so we've increased from that. From where it states today. And then lastly, we have our foundation's annual meeting on Tuesday, January 28th at 4:30. That is the operations report.
Well, thank you. Any questions? All right, then we're going to move on to some of our action items. We've already taken up item A, so let's move on to item B.
So what I'd like to do is, we have a short presentation that will cover both item B and item C. And so I want to just introduce it right now. We have two people, Donald Pipkin and Jerry Randrup, who are going to be doing a short presentation on both the revised mission, vision, values, and also looking at name and logo. I think all of you are aware that we opened as a 150-bed hospital serving 18,000, and we have grown with our community. And now we are really more a comprehensive, integrated system, and feel strongly that now we really need to look at that mission, vision, and values, and our name and logo, and ensure that it really embraces what we are today and be for the next 50 years. So I'm just going to briefly introduce Donald Pipkin. He is our Chief of Strategic Management. He has been with the healthcare system since 2006. He received his Bachelor of Arts degree from Claremont McKenna College, where he majored in environment, economics, and politics with a leadership sequence, and received his Master of Healthcare Administration degree from the University of Washington in Seattle. Then we have Jerry Randrup. She's Marketing and Communications Director. She joined the healthcare system recently in June of 2023 as our Marketing and Communications Director. Her expertise includes healthcare system strategy, marketing, business development, public relations, digital media, internal communications, and better relations. She has devoted a majority of her career to healthcare systems, including Dignity Health, Alameda Health System, and Valley Health System. So I just want to welcome both of them, and we'll turn it over to you, Donald. I believe you're starting.
Great. Yep, thanks, Kimberly, and good evening. You'll see on the next slide, as Kimberly mentioned, what we're going to talk about really tonight is the mission, vision, and values, and that core set of values that this organization and district has had and that has guided the organization over the past 60 years. And it's always good for an organization to periodically test those, get feedback from stakeholders like patients, physicians, staff, et cetera, and then modify those to make sure that they're still in line with our current mission and also the future vision of the organization, and then making sure that the brand of the organization also ties in and represents those mission, vision, and values as well. So on the next slide, we are going to see that the district has been through quite an evolution over the last 60 plus years. You know, the district was founded in 48, the hospital opened in 58, the service league in 55. We had our first intensive care patient in 1963. And then we started to also open some outpatient ambulatory clinics in the area, the outpatient surgery center, rehab. We expanded into Washington West and opened up a number of outpatient services there. Our joint replacement, Washington Women's Center, outpatient wound. We received our magnet certification. We opened up a brand new Morris Hyman critical care pavilion that is seismically retrofitted and able to withstand the earthquakes that potentially could happen in the future. And then most recently started trauma operations. So we've really evolved from a district that was focused and founded with a very specific reason. And as the district has evolved with the residents' healthcare needs evolving, the district has evolved to meet those needs. So it's been quite an evolution, and this is why it's periodically important that an organization go through this process. So on the next slide, what this graphic is really showing is that there's really a key relationship between all of these different components of the healthcare system, whether you enter an acute care setting in the hospital or not, or you're just going to see a medical foundation physician, or you're going to get imaging or lab services, that all of those services act as one integrated system. And that's really where the evolution of the district is today, is moving into that integrated system and making sure that we have mission, vision, and values that are applicable across that continuum, and that we have a brand that represents those mission, vision, and values across the system. So it's recognizable regardless of where a patient is receiving care in the system, that they know it's a Washington healthcare district entity. And so that is the core of the presentation this evening. So on the next slide, I wanted to also let the board know that we have been doing this for a few months now, actually a couple quarters, at least for the mission, vision, and values, and even longer for the brand. And Jerry will get into that. But we did have a very deliberate process of getting feedback from stakeholders throughout the community, you know, and patients, most importantly, district residents, the board of directors, our other entity boards, physicians, service league, staff across the system, acute care, outpatient, healthcare leadership, patient support services, you name it. We did a diagonal slice, and we got a lot of good feedback, and we went through multiple iterations to make sure that we got to a mission, vision, and values that really represented the feedback of that entire stakeholder community, to make sure that it was a set of mission, vision, values, and a brand that could grow with the system as we continue on our evolutionary journey. So a really good process of feedback and discussion with the groups. On the next slide, I will start to go into now the mission, vision, and values that are being proposed and that came out of this discussion. So what's really important, I think, is that we do in certain places have this description that reminds us really the core purpose of the district and why we were formed, founded, and really why we exist today. And we were founded as an independent healthcare district in 1948 to provide residents with health care close to home. And in 1958, we opened a 150-bed hospital, so residents no longer had to travel significant distances to receive care. And as the community has grown, our commitment to local accountability has led us to evolve into a comprehensive health system. Our commitment to patient care in the community drives our vision, mission, and values. And that's really the preamble to the next slide, which is the mission, vision, and values. So out of this process, and the board has seen many iterations of this as well, the mission is, I think, quite powerful and straightforward. And our mission is deliver exceptional, accessible, personalized care to enhance the health and well-being of our diverse community. And it may seem like a simple set of statements and words, but it really, I think, has some profound meaning to it. It speaks to the high quality of the care, the fact that district residents and others can access that care when and where they need it, and that it is personalized, it's individualized. There is a sense of community here in our healthcare district, and that the ultimate goal is to really make the population healthier, both preventatively and acutely. And we grow and change as our community grows, and with the diversity of our community is really important. So I think a very straightforward mission statement. And out of this also came our vision statement, which is be the trusted first choice for care where everyone does their best work. And I think this is the first choice of care for patients, but also for physicians and for staff and for employees and service league and everyone who comes to provide care in the district, to make sure that this really is their first choice where they would like to receive care, and ultimately where everyone along that line of work can do their best work so that they have the resources and the support that they need to do that. And we have 5 values that I think also are really representative of the community. And I've been here for 19 years, and I can definitely attest that I think these really do capture the values of this organization. Number 1 is excellence, providing the highest standard of quality, safe, and accessible healthcare. Patient-centered care, which we hear and talk about and live and breathe in this organization, putting the patient at the center of everything we do. Compassion, responding with care, empathy, and equity in every interaction. Respect, relating to each person with dignity, appreciating the uniqueness of each person and contribution of each team member. And lastly, integrity, acting with honesty and accountability to do the right things. And with that, I'm going to hand it over to Jerry, who will continue the discussion of the evolution and the importance of the brand in this project.
Thank you, Donald, and good evening, board members. Congratulations, President Wallace and the rest of the board on your new assignments, and good evening to colleagues and executive staff. I have the honor of sharing with you in a few moments work that began in June of 2022, and I'm so glad to see Gisela Hernandez here tonight. She actually carried the first torch in that year period before I arrived in January of 2023, and so I'm glad to see her. Let's go to the next slide, please. I'm not going to read you this slide. It serves as a backdrop for me to talk about that diagonal slice and really rich, broad, robust feedback that we gathered that started under Gisela's first year of this project and continued. In fact, I was on a road show for probably about the first 8 months of my 1.5 years plus here, and really gave me a good feel for the organization. And part of the research included a lot of working sessions, certainly more than 5, but I'm going to come back to this graph to talk about some of the key things that emerged. In addition to all the groups we talked about internally and externally, as we met with them, we found a couple of key things that are relevant to this discussion in particular as we revisit 6 years later of our opening, how we have changed and evolved to become much more than a hospital. And some of those themes, comments that emerged included a strong desire to shorten and simplify the name of the organization, since the public doesn't always differentiate between the different entities. And patients often use the shortcut Washington as our universal name rather than stating all of the names that we use across the system. And as I said, we've really grown across to become a much broader scope than our original founding. Through a lot of those sessions, you'll see at this graph lower left, key themes that emerged. First of all, importance to community. And I think not only are our stakeholders feeling this, it is what we message regularly, by the community for the community. A strong need to rebrand, no surprise, our community has become much more diverse, and some of the early findings had to do with the icon that we currently use with the cross and the heart, and questions about relatability to the broader, more diverse audiences, stakeholders that we serve. No surprise with organizational confusion. And then, of course, there are always, and I'm glad to see it high on the list, perceptions around quality. Next slide. As the work continued, we looked at, as we mentioned, all of the entities across the district, and we began to talk in terms of what would be less public facing and what would be more public facing. And this doesn't incorporate all of the entities that we have, and we've grown some since then with trauma and other things. But it really set the framework for how we were going to look at the organization. And certainly rebranding began by looking at numerous aspects of the current branding and messaging. And one area of focus was how we were structured versus how patients experienced the understanding of a larger Washington health system. So this chart got us focused on the user's experience, the public-facing entities, and even though the entire company is more complex, it includes those less public-facing entities. And we also noticed, of course, all the number of names that we've given ourselves across the organization and thought about how that fits to really creating a more accessible, relatable, user-friendly experience. Next slide. So as we thought about those names, to no surprise, and looked at the strengths and weaknesses, Washington came forward. That's a foundational word. It's a word that patients and many other stakeholders, including our own staff and providers, refer to us rather than the longer name. And we found that there was a diminishing connection to the historical township word, especially as we've grown across the district and beyond and are serving patients beyond. And so we looked at the importance of keeping keywords such as health or healthcare and medical. And ultimately, the decision came down to the name change to the shorter Washington Health. So let's take a look at what that now looks like in the proposed brand. Here it is. You saw a little bit in the center of that Venn diagram that Donald shared earlier. You see the colors reflected in how we display, for instance, in this presentation. Now let's look at how it works with some of, well, let me first talk, next slide, about the relatability of this new brand. You'll see, of course, our legacy green, so in the past, while reflecting our evolution from a community hospital into a comprehensive healthcare system. It reflects the expanded scope of services provided and drives the organization to the next level while we're reaffirming our independence and commitment to this community. And it connects the familiarity, as I said, of the district, established as Washington, and shifts the focus to overall health away from episodic transactional care delivery. That's really what, in our mission statement and vision, we are saying we want to do. We want to foster healthier communities. We want to keep people healthy. Ultimately, we'd like to keep them out of the hospital. Now, we'll let the people working in policy figure out how to shift the reimbursement streams to incentivize that further. But that is our big vision. It also reflects our diverse community through differently sized, colored, and curved elements. and symbolizes the continuum of care through that circular form that brings those three diverse elements into a cohesive whole. And it expresses a sense of motion within an organization that is continuously advancing care to foster healthier communities. And as I mentioned, respects our past by bridging that legacy green. And more importantly, I think, introduces blue to promote a sense of calm and freshness. And we know that color does evoke emotion. Next slide, please. Now we'll look at how, just as some samples, the parent name of Washington Health would be paired with some of the public-facing entities, and so it becomes Washington Hospital as the DBA. It becomes Washington Health Bell Neuroscience Institute, or as you can see in our partnership with UCSF Health, that co-branding. Next slide, please. And communicating, you may wonder what's next if the board does adopt tonight. Well, we would be communicating the mission, vision, values, and brand, and we would be looking at an implementation plan that is phased. We are not an organization that's going to toss out everything and flip the switch and overnight have this everywhere. We are going to be good stewards of the resources we have, and so we will begin a phased rollout that would include the brand showing up as a department needs to reorder forms, or as they go into a space within our digital environments. And we're going to start internally. In marketing, we use a term cascade, and what that means is, and I call it inside out, we always want to tell our internal audiences what is happening before they hear about it externally. We want them to be able to ably say, yes, we heard about it last week. We heard about it a couple weeks ago. We're excited about it, some of that messaging. Timing is currently to begin in January of 2025. Next slide, please. And here is where I will pass the torch back to Kimberly.
All right. I know we need to, in order to do the discussion, I know we need to probably have, if there's any questions for the board, or they can ask the question.
They can ask the question.
Okay.
And then
we can do it.
You can have the motions.
Okay, yeah. So as I said, you heard what's being recommended. If you have any questions for Donald and Jerry, again, I think this really represents where we are today and where we need to continue to evolve and be for the next 60-plus years of being able to serve this community as a independent community health system. And again, this is an effort that a lot of people throughout the healthcare system and our community participated in.
Great job, a lot of work, a lot of time, a lot of thought.
Those two were the leaders
Yeah.
and many others, and Tina Nunez also involved. So.
Yeah, we just want to see this all over town, all throughout the district. Yeah. No questions from me, though. I think you guys did a great job.
I like the idea of communicating doctors and nurses, everybody working together as a team. In a circle of care. That's what it's really all about.
Mm-hmm. Yeah. I agree.
Okay, any comments, questions? All right, so can we have a motion for consideration of the recommendation?
Yes, Mr. President, I move for approval and adoption of the new name, Washington Health, and the accompanying logo as the official trademark for the Washington Township Healthcare District.
Thank you. Do we have a second?
I'll second.
Thank you.
Okay.
Cheryl?
Okay. Director Eapen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Thank you. Motion passes. How about consideration of the revised statement of mission, vision, and values of the district?
Mr. President, item C, I move for approval of the revised mission, vision, and values.
Thank you.
Second.
Thank you. Cheryl?
Director Eapen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Thank you very much.
Yeah.
Again. Thank you, Donald and Jerry again for all of your hard work.
Yeah. Yeah.
Thank you.
I know
Thank you.
Hisela was involved at the beginning too, so thank you.
Thank you.
you.
I'm going to
Yeah.
on to the signatures.
Authority, yeah. So, this evening, I am recommending that the board approve resolution number 1270, which approves the proposed board policy number A018 signature and spending authority. I have been working with Paul Kozichenko as legal counsel and with Tom McDonough as CFO to look at the signature authority and update it. It is something that has not been reviewed or revised, I think, for over 20 years at this point.
Easily.
And our health, as we talked about, our healthcare system has become more complex, and really would like to clarify what the chief executive officer can approve that in terms of transactions. I will also bring back a delegation to this board in the future as to how that would go, but proposing that that the CEO signature limit does increase to $300,000 in terms of for any budgeted, non-budgeted, or emergency transactions, and then the CEO may approve budgeted transactions in excess of $300,000 once board approval has been obtained. And then there's also situations where there's emergencies or non-budgeted items too.
Yeah.
So it all is outlined in this policy. I don't know, Paul, if there's anything else.
No, I think that's,
It's simply nice to have that updated to
Yeah.
March. to have
Sure.
Yeah.
It clearly improves our ability and agility to do
Yes,
this.
absolutely.
Efficiency.
Yeah.
Mhm.
Yeah. Okay, well then we will take up a motion then.
Okay, Mr. President, item D, I move that the board approve resolution number 1270, which approves the proposed board policy number A-018, signature and spending authority.
Thank you.
I'll second. I'll go.
Thank you. Sure.
Yeah.
Yeah. Okay. Director Epen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Very good. That motion passed. Any other announcements? No closed session.
No closed session.
Okay, thank you all.
Nice job. Good job, Liz.
So, many of you, we might not see you. I know we're going to have a meeting on Monday. For those who don't, happy holidays, and don't see you on Monday. We'll see you next year, I guess. Thank you. So this meeting's adjourned.
Thank you.